For our next session, Transforming Multiple Myeloma Treatment, Integrating CAR T-Cell Therapy and Patient Care, we're joined by Dr. Raymond Thertulian, Director of the Myeloma and Plasma Cell Disorders Program at Novent Health Wayseeger Cancer Institute, and Selena Lewis, a multiple myeloma patient advocate who has demonstrated remarkable resilience while undergoing treatment.
So I thank you all for being here. I also thank the organizers for inviting me to discuss the only thing I know, multiple myeloma. And hopefully you'll all come out with some information that you can use, because this is a disease that affects the Black population more so than other populations. So obviously I'm joined by Selena Lewis, and I like her better too. Um, so let's start with the basics. I want everybody to know what we're going to talk about, and we start at the same level. What is blood? We all have it. It's not blue. The blood itself we consider an organ because it has all of the functions that any other organ in the body would do, right? It has blood cells, and it has the liquid part of it that we call plasma, right? And if we remove all of the proteins in it, it's called serum, right? So we have red cells in the blood, and a good analogy is they're there to carry oxygen, just like a truck. They can carry the oxygen everywhere in your body because your body needs oxygen everywhere. Yes? And then you have the white cells. The white cells are there to protect you. Think of them as your army. They protect you against infections. They protect you against cancer. So you can think of cancer as a failure of the white cells to prevent it from happening. Yes, that's your army. And then you have the platelets. Okay, you think of the platelet as your ambulance. They protect you. You're in the kitchen, you're cooking, and you cut yourself. The platelets are there to go and plug that hole and prevent you from dying, from exsanguinating, right? From bleeding to death. So these are your platelets. We are simplifying things a bit because they do more than just what's on the slide, what I just said. But think of them that way, right? And this way we can start having a nice discussion about, the key subject of the day, which is multiple myeloma, okay? So all of these blood cells, all of the blood products, right? The red cells, the white cells, the platelets, they are made in the bone marrow. And we all are used to the bone marrow. It's the material that is within the bones. You know, when you take a chicken bone and you break it, that little material that in there, that's the bone marrow, right? And that's where you make blood, okay? Now, what is cancer? Well, cancer is when you have something wrong with one cell, right? It may be a breast cell, and it starts growing uncontrollably, right? It's an uncontrolled growth. Then you have a breast cancer. Similarly, if you have a white cell that starts growing uncontrollably, it's a blood cancer. It's called leukemia, for example. Well, remember the thing that is really very interesting about multiple myeloma or blood cancers in general. This is a cancer of the cells that are supposed to protect you, right? So the white cells are supposed to protect you. The plasma cells that we're going to talk about are the cells that make antibodies to protect you. And these are the cells that are not functioning. So therefore, your immune system is not going to function very well. So this is the disease that we're going to talk about, multiple myeloma, right? It is a cancer of those plasma cells. Those plasma cells are the cells, as I said, that make antibodies to protect you against infections, whether it's viruses, bacteria, mold, mildew. But they can also make you miserable, right? If you have allergies, they produce the same antibodies against grass and whatever else that you're allergic to. These cells produce an abnormal protein. It's an abnormal antibody, and we call that an M protein. So if you have multiple myeloma, you need to follow the M protein. If it's coming down, that's good. If it's going up, that's bad, right? So you follow the M protein, that stands for monoclonal. Now, there are some pre-malignant, right, pre-cancer conditions before you get to multiple myeloma, okay? We have a condition that is, I mean, obviously it's very common in the Black population. We call it MGUS, monoclonal gammopathy of undetermined significance. And the reason why we call it of undetermined significance is because it doesn't do anything. It doesn't cause pain. It doesn't cause any problem whatsoever. The reason why you have to see somebody like me when you have MGUS is because it can develop into a cancer that we call multiple myeloma, which is what we're talking about today. MGUS is very common in the Black population. Therefore, multiple myeloma happens to be very common in the Black population as well. So we all have to be aware of it. If you start having symptoms and your symptoms are caused by your MGUS, it's no longer MGUS. It has already progressed to multiple myeloma, right? And there is a condition in between. So if you come to me with MGUS, I monitor you every 6 to 12 months or so, and I'm watching the progression of that M protein or some other proteins that we call serum-free light chains, and they're going up. You may progress to the intermediate condition that we call smoldering multiple myeloma, okay? And that means the disease is progressing, and you're more likely now to develop multiple myeloma. And we want to catch it early before you break a bone, for example, before your kidneys fail. So there are things that we need to watch for and start treatment before something really bad happens to you, right? And that's very important. So, multiple myeloma in a snapshot. In 2024, right, we're going to have about 36,000 cases. When I used to give this talk in about 2000, 2001 or so, I used to say the incidence of myeloma is about 14,000. So between 2000 and 2024, we went from 14,000 to about 36,000. So the incidence of the disease, the number of people afflicted by this disease is growing rather rapidly, right? But the good news is, I also used to say in 2000 that the death rate, the annual death rate for multiple myeloma used to be 11,500, right? You have 14,000 cases and 11,000 are dying every year. Now we have 36,000 cases. The number of people who are dying every year is just about 12,000, right? So the death rate is not going as high as the number of people that are being diagnosed with multiple myeloma. And that's tribute to the research that we've done and to all of the good drugs that have been developed for the disease. So we've done very good progress here, right? However, as I will show you, the progress is not distributed equally. So the incidence of myeloma, right, as the most common blood cancer in Black people is very high. The mortality is lower, but Black people still die at a higher rate than white people. Fatigue. Fatigue is very common, right? We go to work, we put our 8-hour shift, and we go home, we're all tired. This is not what I'm talking about, right? We're all used to that part. But it's the fatigue that prevents you from doing the things that you used to do, right? You used to walk 5 miles a day or 3 miles a day for your exercise, and all of a sudden you adjust, and instead of doing 3 miles, you say, oh, I'm tired today, I'm gonna do 2 miles. And then next week, you're so tired, say, oh, I don't want to do 2 miles, I'll do 1 mile. You're adapting to your body being tired, being fatigued, right? And if a lot of young patients come to me that way, they go to the gym and they used to do certain things, and then all of a sudden they realize they can't do it anymore. And they come and then we test them and we find that they have myeloma. This is the type of fatigue that I'm talking about. And of course, because myeloma affect bones, it can affect, you can present with back pain. Again, back pain is very common, right? But it's not the usual common back pain. If you have back pain that's not getting better by all physical therapy, then you need to get examined to make sure that you're not developing something else other than just your usual back pain because you lifted something heavy. And then of course, because myeloma can cause anemia, Anemia makes you feel fatigue as well, and you just don't have the energy. Okay, so when you're experiencing those things, and by the way, when you go to your doctor, that's why we have to go to our doctors, and they do your usual complete blood count and complete metabolic panel, they can actually see abnormalities that cue them on doing tests to look for multiple myeloma. Okay, so multiple myeloma, when we go to the bone marrow, right, we go put a needle in that bone there, and we pull the marrow, we send it to the lab, and we find that you have those abnormal plasma cells. Usually, if you have greater than 10% of those plasma cells in the bone marrow, that's abnormal because normal is less than 1%, right? And then we look for some other symptoms, right? We look for, increased calcium in your blood that you can see from the regular blood test that they do. We look for kidney disease, right? But the most common cause of kidney disease is not myeloma, it is hypertension, right? Take care of your blood pressure. Blood pressure is the silent killer. You need to take care of your blood pressure. That's the most common cause of kidney failure. But if you have a controlled blood pressure, and then you don't have diabetes, by the way, diabetes causes renal failure as well. So take care of your blood sugar, and you don't have those problems. Then if you have kidney disease, your kidney doesn't need to tell you why do you have kidney disease, right? And then anemia, low blood count, and then bone disease, because this disease can actually make you fracture your bone. So we look for all of those things to diagnose multiple myeloma, and some other criteria that we do by doing some blood work, right? We call that slim crab, as you can see there. Now, if you have multiple myeloma and we are treating you, your first treatment is your best treatment. It has to be your best treatment because most of the time, that's going to be the longest time that you're going to control this disease, right? We consider multiple myeloma incurable. Although I keep telling people, we have all of the tools, we just don't know how to use those tools yet. So we're doing clinical trials to actually learn how to use those tools to cure this disease. But as of now, we don't consider it curable, okay? Then we treat you, you respond, the disease remains in remission for a certain period of time, and then it comes back. And then we treat you again, which is the second line, and it comes back, and we treat you again, third line, it comes back, we treat you again, fourth line, and so on, right? And we have so many drugs that we can treat you for a long period of time. That's why the incidence, the death rate is lower now because we have such good drugs to treat the disease multiple times, right? So it's, as I said, it's common in the Black population. And we estimate that by 2034, 24% of people diagnosed with multiple myeloma will be Black people, right? It's twice as common in the Black population as the white population. These are just mere facts that I'm giving you, right? Black people are diagnosed 5 years younger than the white population. The average age is 69, and we are being diagnosed at the age about 66, right? Facts. 20%, right, of all African American constitute right now 20% of all patients with multiple myeloma, but we're only 14% of the population, as you know. So clearly, very much increased incidence, and that will continue to increase. This is the slide that I think is important. Now, if you look at this side, is the death rate for white people, and they look the same, but look at the y-axis. It's about 4. You see that? The rate is 4 per 100,000 on that side for white people. If you look at the other side, for Black people, it's 8 per 100,000. So twice as much people are dying from the disease, despite all of the progress that we've made, okay? And there are many reasons for that, okay? We're being diagnosed later than other people because we don't go to the doctor, right? We don't have good access to care. The former speaker, the cardiologist, said exactly the same thing that I'm going to tell you, right? We're not offered the same treatment. We're not offered the new drugs that have been proven to be effective in clinical trials, right? So this is the reason why you need to be informed and know exactly what kind of questions to ask, one. And two, myeloma is still not a very common disease. You need to see somebody who actually treats the disease as their career, right? Who can actually guide you in how you need to be treated. Fact, another fact, right? We call up the triple T's, right? We're not being offered triplets. But this slide is already dated because now we're up to quadruplet. That means 4 drugs. Okay? So we're not being offered the proper treatment. We're not offered transplant. We still know that stem cell transplant is standard of care for multiple myeloma, but it's not being offered to Black people because they know we're going to say, no, I don't want transplant because I read on Google. Don't do that to yourself, right? Because it's standard of care. Millions of people have gone through it and have done very well, and that's why they survive longer, right? And then obviously the newer treatment that we have, CAR T therapy, we're not being offered CAR T therapy. If you take the centers that offer CAR T therapy and you overlay it on the map of where Black people live, there's only one center in Mississippi, right? In North Carolina, we are fortunate because we have Atrium, we have Novant, you have Duke, you have UNC. All 4 of us offer CAR T, so you have the opportunity. But in Alabama, there are very few centers, right? In Tennessee, in where Black people live, they don't have centers that offer CAR T, right? So very few of us get to see this type of treatment. And of course, the 4th T that we talk about, clinical trials. We have a historical issue with getting into clinical trials. I understand that. But clinical trials are very well regulated. And when somebody offers you clinical trials, because it might benefit you, right? If we want clinical trials and you don't participate, then we don't know whether it works for us or not, right? So make sure that you get enrolled in clinical trials so that we know if the new drugs are working for you, right? So in general, Black people tend to have less aggressive multiple myeloma than white people. So you would expect then that if we have less aggressive disease, that we should live longer. Well, this slide says, if you're a Black person and you go to your doctor with multiple myeloma and you are offered the same treatment that they offer white people, Black people live longer. That's on that slide, right? The teal sign, the teal curve is for Black people. The red is white people. Meaning that if you are offered the same treatment that they offer white people, you do better, right? So why are we dying twice as much? Because we are not being offered, okay? That's one thing. But when they offer it to you, you need to do your research and not say, no, I don't want it because Google said, right? Because we have the data to prove that we do as well, if not better, when we are treated the same, okay? So here's something about how we manage multiple myeloma. Obviously, this is a panoramic view. I'm not gonna give you details, right? When you diagnose with multiple myeloma, we need to determine whether you're transplant eligible or transplant ineligible. This is the first thing we do, right? Besides determining whether it's gonna be aggressive or not aggressive, this is the first thing we do. Are you transplant eligible? Then we offer you transplant. Are you transplant ineligible? Then we do different type of treatment. And this is the type of schema that we use in treating multiple myeloma, right? If you transplant eligible, the top one, we give you, the first treatment we give you is called induction therapy. And then after induction therapy, if you agree to go to transplant and you're transplant eligible, we do a stem cell transplant. And then after that, depending on which center and how many cycles of treatment you've gotten, you can get a post-transplant treatment that's usually the same as the induction treatment. And then you go on a maintenance. The maintenance is to prevent the disease from coming back, right? Because as I told you, it's not curable, so therefore we need to prevent it from coming back. If you transplant ineligible for whatever reason, whether it's your age, whether it's comorbidities, like you have diabetes and hypertension and heart disease and atrial fibrillation that's not controlled with a Watchman. Where's my cardiologist? So then we treat you, but again, it has to be a triplet or a quadruplet. That means 3 drugs or 4 drugs. Don't accept a 2-drug regimen because it's not as effective. That's just the way it is, right? Then we give you the same induction and then we give you continuous treatment to prevent the disease from coming back. And if you're treating that way, as you can see, we can control this disease for years. And nowadays, when somebody comes to my clinic, I talk about somewhere between 10 and 20 years. So if you're 70, 75, and I tell you I can give you one regimen and you're going to live into your 80s, I allow you to die of something else. So that's what we call functional cure. So this is actually a list of all of the drugs that I have to treat this disease. We are living in the land of plenty when it comes to multiple myeloma. You just want to make sure they are offering you the proper treatment to live longer, right? Now here comes the future, right? The future, what I think is going to cure this disease is cellular immunotherapy. So what are we talking about? Well, we're talking about CAR T therapy. What is CAR T therapy? Well, remember I told you about the white cells, which is your army. So what we do, we take your T cells. You come, we put you on a machine, we put a big pipe right here, we plug it to the machine spins those T cells out. T cells are your fighters, right? And then we send it to the company, a company like Kite, right, Rolando? And they will take those T cells and educate them to fight myeloma. And the way they do that, they introduce in them some markers, some receptors to allow them to recognize the myeloma cells. And then they freeze them, they send them back to me. And then I bring you back to the clinic, I give you some chemo to prevent you from fighting them because you can reject them. And then I give those T cells back to you. And the only job those T cells have is to go fight myeloma, right? This is the latest treatment. This is the treatment that I tell you that unless you live in a big city where they offer this latest treatment, you're not going to get it, right? So you need to be aware of it and ask, why can't I get a CAR T? Because CAR T now is approved in the second line. So that means after I give you an induction and I give you a transplant and the disease come back, I can take you to CAR T. But I can guarantee you're not going to be offered because you have to live within an hour from the center. You have to have a caregiver. There are a lot of criteria that you have to meet to get CAR T, right? The other thing is bispecific antibodies. Bispecific antibodies, also cellular immunotherapy, it is, an antibody looks like this, and a regular antibody, both ends attack the same thing, right? In a bispecific antibody, this end can recognize myeloma, this end can recognize the T cells in your body and bring them together, and then the T cells say, aha, let me kill myeloma. So essentially, it's also, even though it's an antibody, it allows the T cell to kill multiple myeloma, okay? And of course, let's talk about clinical trials. The only way we know what we're doing, the only way we develop those drugs is through clinical trials. And if you don't participate in clinical trials, as I said, we don't know if it works for you, right? Very few people participate in clinical trials. And I put this slide up, I cannot read it down there, to show you that we have, let's say in myeloma, for all of the trials that we've done, about 70,000 people who are participating in clinical trial. 90 to 92% of them are white. About 1,500 people are black. Now, how can I tell that whatever I'm developing actually works for you? I am extrapolating. I am thinking that it may work for you, just like it worked for other people. But I don't know that for sure because we don't have enough black people participating in clinical trials. So please, when you go see your doctor, whether it's in myeloma, whether it's in breast cancer, whether it's colon cancer, whatever it is, whether it's blood pressure, testing a new drug, right? Because the black with blood pressure, high blood pressure, doesn't respond to the same drugs that other people respond to, okay? Because our renin-angiotensin system works differently. So make sure you participate in clinical trials so that we can make sure that we develop drugs that actually benefit you. Okay, so I'm gonna stop there, okay? And I'm going to let my co-speaker, Selena, talk a little bit, and then we both will take questions if we have time. I think we will have time.
Okay, thank you so much. I want to say thank you to Dr. Thatulian. He's amazing. When I first got diagnosed, I was referred to Dr. Thatulian from my hematologist. My primary care physician, it said that I needed to find out what was going on because I was indicating as anemic, and some of my blood work was not looking normal. And I'm not one to go and Google everything. So when I went to my other hematologist, and she said, "Well, I'm sure you've Googled it by now and know that it's an indication of cancer." That was the first I'd heard of it, and I was, I'd heard of multiple myeloma only because one of my really dear friends had passed away from complications from multiple myeloma the year before. So when she said that, I was like, oh my God, this is a death sentence, and I was, at the appointment by myself, broke down, crying, and she referred me to Dr. T. And my first appointment with him, he explained just like he did today on, about the disease. And I felt very comfortable going under treatment with him. And my situation was a little different, the average age, as he was telling you, I'm a lot younger. I'm at 51 when I got diagnosed. I'm 52 now. And so I didn't have any symptoms other than the fatigue. I had some minor back pains, but it wasn't, anything horrible. And then, of course, the blood work was with the indication of what was going on. And I had to, certainly pray about it, but I trusted his guidance. And I went through the induction therapy, and that didn't work for me. And when I went to that appointment, I was like, okay, I have some strange form of this disease. It's not working. And ended up having to have additional chemo. But thank God that I did qualify after that for the stem cell transplant. So I went through the stem cell transplant in August of this year, and I am doing well. I went from 90%. Thank you. Thank you. Yes, I went from 90% of my plasma cells involved down to 15%. So I'm very thankful for that. So I am going to have to go back for a tandem transplant. So please keep me lifted up in prayer. December 4th, I will be going back for my second stem cell transplant.
So that's a very interesting thing that Selena just said. Sometimes we do offer what we call a tandem transplant. We don't do it often these days. I used to do it a lot in the early 2000s because that's the only effective treatment we used to have, right? Transplant. Now we have all of these very effective drugs that we can use, so we rarely do tandem transplant. But in Selena's case, because she had what we call refractory disease, right? She didn't respond to the initial treatment, but she still had what we call chemosensitive disease. So we did the first transplant. So we were able to actually decrease the tumor burden significantly. Then, well, if one worked, why not do two? So that's why we're doing a tandem transplant to try to bring her into the deepest response that we can, because in multiple myeloma, response, the depth of response matters, right? We always want to bring patients to the lowest amount of disease possible, right? And that's the plan for Selena as well. I think we want to take some questions. We have a question right here.
December of 2020, I retired from the government. 42 years. Stood on my feet for 42 years. August of 21, I was diagnosed with CMML. I started getting treatment, chemo. February of 22, I had transplant. Okay. Today, I'm in remission. So
That is excellent. CMML is another disease of those white cells that we talked about, which is obviously a different white cell than plasma cell. By the way, we have better treatment than for myeloma than they do for CML. Just as an aside, but I'm glad that you're doing well and that it is in remission, because CMML is one of those conditions of the white cells that can progress to it's a chronic leukemia, but it can become an acute leukemia, and it's really bad when it becomes an acute leukemia. So I'm glad you're in remission, you're doing very well, and continue to follow with your hematologist.
How did this condition change your day-to-day activities? Because I know you're a very active person in the community, in your occupation. Can you speak to someone that may be struggling with this? How, it kind of changed your day-to-day activities. So
Yes, absolutely. For the induction phase of chemo, I worked the entire time in very long hours. I wouldn't suggest to someone to do as much as I did, but I got to, when I finished with the induction phase of therapy, I had to do 96 hours of straight chemo, which I had to be hospitalized for. And I will say, even the first 2 days that I was in the hospital, I was still working because it was not planned. I thought that I had a little bit more time to before I had to go out of work, but I ended up working up until that point, and it does change your life. Like he talked about, I used to work out all the time, and then I got too tired. And I was walking 5 miles a day. Then I was like, well, maybe I'll just do 3, 2. Well, maybe I could just walk 1 mile, and that's what I ended up. But I still moved. I still got up and exercised every day, even throughout transplant. So it definitely takes a lot out of you. The fatigue is real. The after transplant, there were days that I felt like I slept 20 hours, and I probably did sleep 20 out of the 24 hours in a day. But I thank God that I'm still here.
Key.
Okay, last question right here. Oh, did you have?
My name is Marcia, and the reason I'm standing is because I lost my daughter November 7th to multiple myeloma. She battled it for 6 years, and she also had a stem cell transplant, but she was able to use her own stem cell. My thing is that she had been taking blood transfusions because of anemia, and I'm just wondering why it took so long for them to diagnose it. Because the first time that they saw there was an issue was when her kidneys were failing, and that's when they went and looked deeper. It seems as though the medical profession doesn't look deeper into our situations. We talk, but then once they give you a diagnosis and you go back the second time with the same issue, they don't say, well, let me look a little bit deeper.
You
And
raised
wind up in these situations. But she battled it for 6 years. And I know, as you said, that you kept working. That's how my daughter was until the end. So
you raise an important question here, and this is the issue, right? You go to your doctor with anemia, and the first thing is the most common cause of anemia is iron deficiency, right? For a young woman, it's going to be iron deficiency. However, if you have anemia and your iron is normal, then somebody needs to dig deeper, right? And that's how you're going to find the multiple myelomas. And that's unfortunate that, if you go to your doctor, for example, another example, and you have kidney disease, and as I said, your blood pressure is fine and you don't have diabetes, somebody needs to tell you why you have kidney disease. And I've been pushing the kidney doctors in this town to do more kidney biopsies. Yes, there are risks to kidney biopsies, but you don't know why you have kidney disease, then you should ask, why, doctor, do I have kidney disease? Because oftentimes we find those other conditions that can be treated early before they become a big issue and affect your life expectancy. So this is one of those things. We have to go to the doctor, but we have to be our own best advocate and ask questions.
Disease. She didn't have kidney disease. That's when they
she had anemia,
and they were giving her weekly injections for anemia. So, just if they're giving you injections and you're not getting any better, I guess you have to be your own advocate. And they just found out that she,
especially as a young person. That is correct.
Thank you.
Question?
Hi, Dr. T. I have a question for you. Two questions, actually. You could probably answer them pretty quickly. So, the first question is on your slides, you showed that there was an increasing incidence of African Americans, or is this all people that are getting diagnosed with multiple myeloma? And if in that increase, do you see if there's an increase in younger people getting multiple myeloma? So you can answer my first question.
Yes. So that's a very, very astute question. And the answer is yes, 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 and yes. Oh. So yes, there is an increased incidence of myeloma for all people. Yes, there's an increase of multiple myeloma in the Black population. And yes, there's an increased number of young people presenting with multiple myeloma. Yes.
Okay. And my second question.
And young patients in the Black population as well.
Wow. Okay. So my last question is, I noticed that a lot of participants who have struggled with a hematological malignancy has said, okay, we've been given transplant. And being that I work in the CAR T space, I want to know your thoughts about specifically because we see in lymphoma, CAR T is going head to head to transplant with transplant. Do you foresee, especially for younger patients, that CAR T would be a little bit more considered curable than transplant?
Yes. So we are doing similar trials where we're comparing CAR T with transplant. So it's not just lymphoma doing it, we're actually doing it in multiple myeloma as well. And remember, I mentioned the fact that we have all of the tools, we just have to do the clinical trials to determine how we use the tools to cure this disease. Well, these are the trials that are being run. We don't talk about treating with curative intent, but when you run a trial where you're using CAR T upfront, to me, one of the reasons that you do that is to deepen the response and do it with curative intent. So yes, we are doing these type of trials, and hopefully, in 5 to 10 years, we'll start having some interest.